It's an honor to chair a session, the Oration, which is by Dr. Rishma and Dr. Hrishikesh. They're good friends and they are very big, very excellent academicians and very dynamic persons. And the talk will be delivered by Dr. Ameet Patki, who is, you can all just new incoming president, and he's a vibrant and also very dynamic academicians and down to the earth in the knowledge. And his deliberation is a very new topic, which is just we have heard the ovarian aging, and this will touch the other side of the spectrum, the male part. And there will be a lot of talk on the different dimensions. I will be very happy to know. And nobody, I think here in this hall, everybody is aware of his credentials and his biodata. And he doesn't need any introductions. And you have gone through all the achievement of Dr. Patki. And his speech will always tell you what he is. Thank you, Dr. Patki. You can start.
A very good morning, and I'm so glad to see all of you and welcome to ISAR 2024. I would like to profusely thank Dr. Nandita Palshetkar, Dr. Sujata Kar for a wonderful conference in Bhubaneswar. I'm also honored and humbled to deliver the Dr. Hrishikesh Pai and Dr. Rishma Pai Oration, two of my friends. And I look forward to a great year with all of you in ISAR. Can I have the first slide? If you look at this video, it is the perfect male through the eyes of the artist. The statue of King David, done by Michelangelo in Florence. And when we look at this, we find that it is so well chiseled and so well proportionate that Michelangelo, at a mere age of 26 when he finished this, he hit the chisel on the thigh of the statue and said, "Speak." Because he believed that it was so lifelike that this statue would be able to speak. So when we look at this statue, it tells us it is a fertile man. But is fertility at the right time the perfect age? And that is what I'm going to try and speak in the next 30 minutes. And my oration is titled, Tick-Tock Why? Cracking the Code of Men's Biological Timekeeping. Dr. Nandita took us through maternal aging. And whenever we talk of aging, particularly in infertility practice, we always assume it is the woman's age which causes the problem. So I want to ask you, ladies and gentlemen, is aging a woman-only problem? It looks like, look at these time cover magazines. The life of living longer, it's women. Forever young, again a woman. How to live to be 100 and not regret it, again women. But I believe that it is a man's problem too. And when we talk about curing for aging, I think it should be addressed to both. And similarly, in fertility practice, I think it is time we awaken and we awaken our couples that the man's age is as important as the woman's age. I'm waiting for covers like this, menopause. I'm waiting for a cover which says the man's biological clock, because I think it is time now to speak on paternal aging. James Crow, a professor at Wisconsin and a very prominent geneticist, in one of his review articles said the greatest mutational health hazard in the human population at present is fertile old men. And I've put some pictures of some famous personalities. Do you know what is common in all of them? They have all fathered children after the age of 55, some of them after the age of 60 and even 70. And then he concluded in his review, the genetic health of the species is now facing a serious threat. But is this something new that we are talking about paternal age? I don't think, because this picture is from the school of Athens, where the teacher Plato is asked by his student Aristotle over 2000 years ago. And he asked him that we say that parents should be in the prime of life. So the teacher says yes. So he says, what is prime of life? And the teacher says, a woman, I said, at 20 years of age may begin to bear children to the state and continue to bear them till 40. A man may begin at 5 and 25 when he has passed the point at which his pulse of life beats quickest. He's come out of his adolescence and continue to beget children until he be 55. I think our ART rule says just the same. 2,000 years back, this was known. And he says this is the prime of physical as well as intellectual vigor. And if the children are born before or after, it is an unholy and an unrighteous thing. And this child, if he steals into life, which means if he passes the stage of unexplained stillbirths, which happen, this child will be the offspring of darkness and strange lust, which means that there will be epigenetic changes in this baby that is born. You look at this article from John Atkin, which has been titled very on the face, Male Reproductive Aging, a Radical Road to Ruin. And why does he say that? He says that when there is advanced male age, there is dysregulated cell metabolism, environmental toxins, unhealthy lifestyle, hypertension, diabetes, comorbidities like obesity, which will reduce the antioxidant protection, which will then increase the ROS, and he calls it as the redox imbalance. Along with this, there is reduced testosterone production, and this will then reflect as benign prostatic hypertrophy, erectile dysfunctions, subfertility, and advanced paternal age also leads to increased miscarriages and mutations in the offspring. If we know all this, why is there not much of research? Unfortunately, funding for paternal aging is a mere less than 1% of all medical research budgets. If you go on the clinictrials.gov, you find that there are 239 trials looking into female infertility and 223 trials supposedly looking into male infertility. So on the face of it, it looks that there are enough trials in both. But when you look at these 223 trials of male infertility, you find that 69% of them actually deal with female infertility, 9% are for IVF, and 2 deal with outcome of offsprings. So as of now, there are only 47 registered trials which are actively recruiting for male infertility. And then we talk about women empowerment. We know the sperm count is declining at an accelerated pace globally. This shows me the average counts in 1973 were around 100 million per ml. In 2018, it has come down to a mere 49 million, more than 50% drop in 50 years. And if you break this up, you see that prior to 1972, the decline was 1.16% globally annually. But if you look at papers which are post 2000, you find that the decline is 2.6% per year. So I don't know where we will be in the next 50 years. This paper by Yash Khandwala, somebody from Mumbai, has said that the age of fathers in the US is rising, and he has looked at millions of births which happened in the US from 72 to 2015, and he said that the mean age has increased from 27.4 to 30.9, almost 3.5 years increase in the average age of fathers in the last 50 years. This is a very busy slide. I don't want you to read through it. But the percentage of fathers of newborns older than 40 has increased from 4.1 to 8.9. So there is almost a double increase of fathers who are more than 40. And fathers who are older than 50 has increased from 0.5 to 0.9. Again, almost a double jump. And this is seen across ethnicity, race, paternal education, religion. So it is across global, across all strata of people. The total motile sperm counts that we always want to know has decreased over the age. We know that along with that, the concentration or the volume of semen is also decreasing. And I've highlighted you men between 46 and 50, where we find that the volume is become half, the motility has reduced by 20%, the total motile count by 30%, and the morphology has reduced by 2% over the average semen analysis. So men less than 45 years had a significantly greater semen volume than men over 45 years, and there is a significant decline in the semen volume as men aged. And if you look at all the parameters in semen analysis, be it volume, be it sperm concentration, sperm count, motility, and morphology, have steadily decreased. So over the ages, the sperm DNA fragmentation also has increased with male age. And what is frightening is that the risk of achondroplasias have increased, and the risk of Y, X, and 21 aneuploidy sperms are also increasing. So the probability of producing an abnormal semen sample with increasing age, there is decrease in mortality, increase in DNA fragmentations, increase in achondroplasia mutations, a decrease in count. However, the aneuploidies in the sperms have not increased dramatically with age. So when you look at this graph, there is decreased implantation with increased paternal age, which reflects as decreased pregnancies, increased miscarriages, and hence a decreased live birth. And this particularly starts getting exponentially worse after the age of 45. So when you look at this graph, the months to conceive by paternal age starts rising after the age of 45. The incidence of risk of miscarriage also takes an exponential jump after the age of 49. And we know now that fathers between 40 to 44 years were 23 times percent more likely to contribute to the incidence of spontaneous miscarriages before 20 weeks of gestation. And when the paternal age was more than 45, the risk of loss before 20 weeks was increased by 43% from 23%, and before 13 weeks, the incidence increased by 74%. So we know that with age, there is an increase in the incidence of miscarriage before 20 weeks of pregnancy, and it gets worse even when we look at the data of less than 13 weeks. But there is some good news. The good news is that paternal age doesn't reflect in aneuploidies. So this paper from 2017 in ASRM tells us that 243 egg donor ICSI cycles, which were tested with PGTA and NGS, found to study the effect of paternal age and found that there was no paternal age effect on embryo aneuploidies. And the same was presented in 2019, where there was no significant trend in the prevalence of aneuploidies across the age groups. And this was seen for monosomy, trisomy, for partial deletions or duplication. So there is no aneuploidy associated paternal age. So why are we worried then? Why am I saying that the miscarriage rates are high, implantation rates are high? This is because the blastocyst ability in a increased paternal age is reduced. So this is again showing you the graph where it is seen the first group is less than 39, the second group is 39 to 49, and the next group is more than 49. You find that the euploidy is same, the aneuploidy, the second block is again same, and mosaicism is again same in all three columns. This was from the largest center which gave 3,000 embryos for testing, and so the strength is that it is a single center evidence. So why does Y matter in our clinical practice? It is because the probability of obtaining an optimal embryo decreases with paternal age because it affects embryogenesis. So father who is 25 years old has a 53% chance of making a 4-cell embryo and a 38% chance of making an 8-cell embryo. When you compare it to a father of 45 years, the 53 comes down to 35 and the 38% comes down to 20% chance of making an 8-cell embryo. So this paper looks at various parameters, including mother's age, father's age, BMI of the father, and BMI of the mother. And what is surprising is that the father's age is the determinant which is associated with the optimum number of blastomeres at day 3. It's not maternal age. And the next is BMI of the father. So look for obesity in the husbands if you are finding that there is poor fertilization. The ESHRE has come up with this, which says that society mostly focuses on female fertility, and this is a wrong perception because the burden comes only on the females. They say that we have forgotten the why, which is essential, and we need to look at the effects of advanced paternal age, inherently more challenging than advanced maternal age, and the effects on the clinical outcomes in natural and artificial conception are still not investigated, and this is partly because of very poor funding which is directed to paternal aging. And although advanced paternal age is not clearly defined, clinicians should counsel men who are more than 40 for increased adverse risk for health of the offspring. So can I say that reproduction can be a window for a health in man? We know that when there is infertility in men, it is associated with various health issues, and there's growing evidence to suggest that a diagnosis of infertility increases the likelihood of developing future cardiac, metabolic, and oncologic diseases. So when you look at this as reproduction as a window, you find that when there is in testicular cancers, there is a growing evidence of male infertility. When you look at all cardiovascular diseases, there is a moderate evidence. Ischemic heart disease, moderate, and cardiovascular disease mortality is related to the number of offsprings that he has fathered. Diabetes, strong evidence with infertility. Autoimmune rheumatic diseases, psoriasis, moderate evidence with male infertility. Now, why is this happening? Look at this video. This video is showing you how the DNA breaks up into two. And why this is important is because when there is DNA damage, it is associated with a lack of chromatin compaction. So the chromatin is not very well compacted, and this causes retention of histones. And we know that the DNA damage in human spermatozoa is a two-stage process. In the first stage, when there is remodeling of the sperm chromatin during spermiogenesis is impaired, it leads to a poorly compacted sperm nucleus with a high ratio of histone to protamine. And this vulnerable DNA, which is not well compacted, large amount of histone will cause DNA breaks, and this DNA breaks are exaggerated when the ROS is increased. So you have chromosomes which are normal, so the aneuploidy rate is not increased, but because of the DNA breaks that is happening, you start getting epigenetic changes, because as you know, the amino acid sequences are broken, and now they will code for some wrong proteins or irregular proteins. So fathers transmit DNA modifications to offsprings. Environmental, lifestyle insults, endocrine disruptors, smoking and obesity affects the spermiogenesis, and these sperms are insult happens in the development in the testes or during maturation in the epididymis. Increase in the histones will cause break in the DNA. Less compaction will cause altered gene expression in these zygotes when such sperms go and fertilize the egg. So this gentleman, Weinberg, way back in 1880, said that the incidence of achondroplasia was increased in the last born high order children, which means that one of the last children in normal parents managed to get achondroplasias. And he couldn't explain why, whether it was the paternal age or the maternal age, but now we know that when you have these gene mutations, it is now related to the paternal age. Penrose in 1955 in the Lancet demonstrated that it was the paternal age and not maternal age which was predictive of de novo mutations. And he explained this to say that spermatogonial cells replicate every 16 days. So there are approximately 200 divisions by age 20 and 660 divisions by age 40, which means that as the man grows, the number of divisions are increased, and if there are going to be breaks in the DNA, these breaks are going to accumulate over a period of time. Now, this doesn't happen in the females because the oocytes undergo only 24 cell divisions. All but the last occurs before the woman's birth. So all the divisions in the woman happen before she is born. In men, it is related to the age. So older the man, more chances of DNA breaks, more chances of getting abnormal amino acids produced, and more chances of DMD, which is de novo mutations. So this has very well shown by Stephen Hansen in Icelandic families. He said the rate of de novo mutations increases with the father's age, and that is why you have these epigenetic changes that are happening. So I come back again to James Crow, who said that fertile old men is the greatest mutational hazard that we will face in the near future. When you look at what are these DMDs, you can see that there's a higher incidence with paternal age as compared to the maternal age. So on average, the offspring that is born to a 40-year-old father harbor twice as many genic mutations as the offspring who was born to a 20-year-old father. And what about the 70-year-old father? That offspring had 8 more times de novo mutations as compared to a child who was born to a 20-year-old father. So mutations in older fathers are not only more in number, but they are also individually more likely to have functional consequences, because it just tells us that the amount of wrong amino acids that are produced is high. This again is a slide which you may not be able to read, but this tells us that advanced paternal age is a health risk to the offspring. And what are the health risks? Increased incidence of achondroplasias, thanatophoric dwarfs, osteogenesis imperfecta, Pfeiffer's disease, autism, schizophrenia, and bipolar disorders. So understand that advanced paternal age is linked to autism, and this graph tells you that the incidence starts rising and then shoots up after the age of 40. Similarly, incidence of schizophrenia in children born to older fathers starts rising, particularly after the age of 50. So, ladies and gentlemen, the man's biological clock is ticking, but at what age will you draw the line? And this, Dr. Minoz's clinical data helps us to identify the age as 50. After the age of 50, most of these epigenetic changes, gene mutation changes, will suddenly start going up. This can be tested by the DFI, the sperm DNA fragmentation. There are 3 thresholds. Those having less than 20% of DFI, which is in 60% of the patients, no problem. Those having DFI between 20 to 25%, which is 10% of patients, they are in the gray zone. And those having DFI more than 25%, which is 30% of patients, are in the red zone. So those in the green zone, as I would say, they would spontaneously conceive or at the most need IUI. Those in the gray zone are the ones which will definitely need IUI, and some of them, depending on the paternal factors, may need IVF ICSI. But those with a DFI of more than 25 would definitely need IVF ICSI. And look at that graph, which also shows that there is an increased incidence of miscarriage in these patients. So what did Dimenzo recommend? How to manage these patients in the gray and the red zone? He said, prefer to use supplements that support 1 carbon cycle, because this is involved both in methylation and in the synthesis of 3 major antioxidants: the hypotaurine, the glutathione, and the CoQ10. So when you look at this age-related CoQ10 deficiency, it leads to compromised energy production and a compensatory increase in ROS. So paternal aging, increased oxidative stress, increased lipid peroxidation, increase in the ROS, which will cause abortive apoptosis, oxidative damage to the sperm germ cell line, decreased compaction in the DNA, increased histones leading to increased DNA breaks. Over a period of time, the DNA breaks increase, and that will then cause DNA mutations in the offspring, increased miscarriages, increase in autosomal and sex-linked dominant genetic diseases, increase in childhood cancers, increase in metabolic disorders, and psychiatric illnesses. Now, the eye opener to us and why I got into paternal aging was we studied 100 couples who came to us with a previous IVF ICSI failure elsewhere and where no male factor was documented on paper. We did their sperm analysis and their DNA fragmentation, and we found that almost 60% of them had an increased DNA fragmentation of more than 40%. When we evaluate with them, we found that 24 of them were over the age of 40, 21 were diagnosed by us as pre-diabetic or diabetic, 12 of them hypertensive. Obesity with a BMI of more than 30 was found in 9. Smoking more than 25 per day was found in 20. So this was all missed because they had merely looked at the semen report, which said everything was fine, and they proceeded ahead. So when we looked at these men, we treated them with antioxidants over a period of 90 days. We found that their DNA fragmentation came down. We gave them a multi-blend of micronutrients because we know that every micronutrient acts on the particular part of the sperm. Like vitamin C, vitamin E will work on the sperm head, the CoQ will work on the neck, and the zinc, selenium will work on the sperm motility. Once we retested their DFI fragments, we found that those who had severe oligo, less than 5 million, responded better to these nutritional supplements than those who had mild oligo. We had almost 170% increase in the sperm count over 90 days. Mind you, lifestyle advice was given to all the patients, even those that were on placebo. And that's why some of the placebo patients improved on their own because of lifestyle changes, exercise, diet, weight loss, stopping smoking. And we found that there was a significant statistical increase in the percentage of DFI. Again, in those groups where the DFI was more than 40, and in some cases it was more than 80. So we found that these groups responded better to nutritional supplements, and we published this as an original article in a peer-reviewed journal. So to sum up, how do you guide these patients? Clinicians should advise couples with advanced paternal age of more than 40 that there is an adverse risk of health outcomes for the offsprings, de novo and intergerm germ cell line mutations, sperm aneuploidies, increase in birth defects, and genetically mediated conditions like schizophrenia, autism, and chondroplasias in the offsprings. So genetic counseling should also be offered, in my opinion, to patients with recurrent pregnancy loss. I think we need to look at the male factor in recurrent pregnancy loss, particularly by doing sperm DNA fragmentation, because we know that increased sperm DNA fragmentation is associated with an increased incidence of miscarriage. So ladies and gentlemen, there is a discord. We all talk about maternal aging, but I think we need to open our minds to paternal aging. I thank you very much for a patient hearing, and I wish all of you a happy stay in Bhubaneswar. And I think this conference is super success. But in my mind, a success of the conference means when you go back and do at least one change in your practice than what you were doing before you came to the Congress. So I think I want to see that one change in all of you when you go back with all the multiple fantastic speakers that we have got from across the world. So thank you once again, and I hope to see you all next year in Lucknow. There is a small inauguration for the Lucknow conference at 1:30, and I'm sure you will all join us and more larger numbers in Lucknow. Thank you very much.
Thank you. Thank you so much, Dr. Ameet Patki. This was not only a eye-opening, but truly a mind-opening, thought-opening, and the practice-changing talk that you spoke about. So really, really phenomenal. I think lots of us here are female fertility practitioners and don't focus so much on the men. But after this talk today, it's been really a dramatic thought change. What you showed us, how thousands of years ago they said that you should have a baby between 20 to 40 for the girls and less than 55 for the men, was completely amazing. And all of us know the rapid declining rates, 50% reduction in male fertility over the years. So these are dramatic numbers and, really areas where we need to focus on. All of us were aware of autism risk increasing in older fathers, but this achondroplasia and, the massively increased skeletal disorders and other gene mutations is something we hadn't focused on so much. So we all know there's been a lot of unorderly or disorderly practice, like really older mothers and older fathers, being treated by ART specialists over the years, and which is why, unfortunately, a fairly strict law had to come in. But that law at least will now focus on the fact that men have to have their children before 55, at least with ART. So thank you for bringing this really important subject into the limelight, into focus. And believe me, this is one thing we are going to change and focus on when we go back. Thank you so much. Amazing oration. Thank you.
Thank you very much, Ameet, for this very common subject, that is which we are facing, the male partner. But you have selected the right topic, which should be discussed, but very, very rarely discussed. So thank you very much on behalf of the organizing committee as well as all the participants and also the delegates. Thank you very much for selecting this subject and speaking before all of us. Thank you very much.
For the plaque, can I
Thank
also
you,
request
Ameet.
Dr.
Thank you so
Hrishikesh
much.
Pai sir to please join in, Dr. Nandita ma'am.
So we are so happy and proud to present this beautiful plaque to Dr. Ameet Patki, which reads, the ISAR, Dr. Rishma Pai and Dr. Hrishikesh Pai Oration, delivered by Dr. Ameet Patki on the topic, Tick-Tock Why, Cracking the Code of Men, Biological Timekeeping, on 3rd February 24 at Bhubaneswar. So huge congratulations and thank you so much. All the best for a fabulous tenure.